Hello, everyone, and welcome to the September Life Unites Us webinar, Grassroots Advocacy for Addiction, Prevention, Treatment, and Recovery. I appreciate your patience, but we have a fantastic 60-minute event ahead of us. And I'd like to get started with some introduction, so feel free to use the chat box to share your name, what organization, what city you're joining us from. We love to see who's in the audience and get them fully participating. All right, so as folks found some general housekeeping. This webinar will be recorded and available on the Life Unites Us website, along with a copy of the presentation. Unfortunately, folks will be muted throughout the presentation, but using that chat box or the Q&A feature, we'll be able to receive any of your questions and read them out during this session towards the end of our call. For best audio quality, I consider listening to the webinar via phone line by using the dial-in number or switching from computer audio to phone audio. Our agenda today will now include an overview of the campaign by our fantastic coordinator, Ashley Narvaez, and then a presentation brought to you by Bill Stauffer and Shannon Ash before we go into question and answer. Ashley, would you like to come forward?
Hi, everyone. So happy to be here. Thank you so much for joining. For those of you who haven't joined our webinar before, just giving a really quick overview of our campaign before jumping into our presentation for the day. So just to give a little overview, we are the Life Unites Us campaign. We are an evidence-based behavior change public health intervention designed to reduce addiction-related stigma of substance use disorders in the state of Pennsylvania. We are statewide. The campaign is a collaborative effort between Shatterproof, Penn State, and the Public Goods Project in close partnership and funded through the Department of Drug and Alcohol Programs. So as I mentioned before, the goals of the campaign are threefold. We're working to increase knowledge about substance use disorder and that recovery is not only possible, it's probable. We're working to improve attitudes towards living with and in recovery from SUD, and we're strengthening the capacity of stakeholders who are already working on the ground. Next slide, please. So in terms of our pillars of work, we work very closely with the community. We work to engage community-based organizations across the state of Pennsylvania. We realized very early on that community leaders are trusted messengers within their communities. So to increase the reach of the campaign, we try to build capacity for those interested in incorporating stigma reduction work into their programming. We also have a community impact committee, which is made up of community leaders across the state of Pennsylvania, to make sure that our campaign is guided by and for the community. In terms of content sharing, the bread and butter of our campaign is our story collection work. So working with individuals across the state of PA to collect and share stories of recovery and anti-stigma messaging focused on changing behaviors and speaking to hope and recovery. And lastly is our education piece. So we host webinar series like the one that you're attending now to educate and then also build capacity for organizations looking to learn more about specific topics within their field of work. Next slide, please. So this is just an example of some of our digital assets that we share on our social media pages. If you were to visit our website, you could see our collection of stories. We have over 200 stories that we've collected at this point from people across the state of Pennsylvania who are sharing their recovery story. And then just lastly, on this next slide, if you haven't done so already, please feel free to follow us on Instagram, Twitter, and Facebook. Visit our website if you're interested in sharing your story or becoming a community partner. And with that, I will go ahead and introduce our first speaker, Bill Stauffer. Bill is Executive Director for the Pennsylvania Recovery Organization Alliance, PRO-A. He is in long-term recovery for over 3 decades. In 2019, he won the Vernon Johnson Award for Individual Recovery Advocate of the Year at the America Honors Recovery Dinner. And he's an adjunct professor of social work in Dallas, at University in Dallas, Pennsylvania. So Bill, over to you.
Thank you very much for the introduction. It's an honor to be here today. Again, my name is Bill Stauffer, Executive Director of PRO-A. I have a lot of material to cover, and just for the benefit of people I have a link that I'll share with a lot of the background information involved as well. So we are PRO-A. We are the statewide drug and alcohol recovery community organization of Pennsylvania. We've been in existence since 1998, one of the original recovery community organizations in America and founding member of ARCO, which is the National Association of Recovery Community Organizations. Briefly, we want to talk a little bit about storytelling, how to communicate with members, stakeholders, and family members, thinking about inspiration and how to build advocacy community and advancing goals of your organization and what we would call the recovery movement. We want to spend a little time exploring existing rights of persons with a history of SUD and examine policies that address stigma and discrimination across our state and beyond, and also think a little bit about resources on care models, trainings, and educational materials. And again, I provided this also in a link. So one of the things, common theme that came out of something called the New Recovery Advocacy Movement is sharing stories. I'm 36 years in recovery. When I got into this field 35 years ago, people in recovery who were working didn't share their stories. It was something that's relatively new, about 20 years. And so these themes and how to tell your stories is, relatively speaking, a new thing. What I'm talking about today in sharing truth, your own truth, talking with conviction, using examples from audience perspectives, and how to frame your story is actually something that occurred out of that movement. Tom Coder, who's our Deputy Assistant Secretary of SAMHSA, is also a person in open recovery. And I've talked to him about what this training meant to him when he was in early recovery in a recovery community organization in Connecticut. You want to think about what you're saying and how you say it in ways that connect with your community. So if I say, my name is Bill, and I'm a person in long-term recovery, starting at age 21, and then what it has meant for me is I've been able to have a productive life and be an active member of my community. That sounds a whole lot better than saying, my name is Bill and I'm a drug addict. It gives you an entirely different image, and actually it's a lot closer to who I am. So you want to think about that. And when you share stories, you want to think about the audience that you're involved with when you're sharing it. We also want to think about our boundaries when we're talking about sharing our stories. What do you want to include? And why you're including it, what kind of information would be oversharing, facets to stories that may impact other people. And so for persons who are in, say, 12-step fellowships, a person in a 12-step fellowship, inside of that room may share a very different version of their story when they're talking to people who have that shared lived experience than out in the public. Public storytelling has a different focus and a different message. So you want to think about that. And in having dialogue with people about what kind of information we share, I mean, I am open about having lost 2 immediate family members to addiction. I don't share the details of that. It's important for me to have you know that I'm impacted as a family member as well. But out of respect for my surviving family members, I don't share the details. I've talked to colleagues who will not share details of their story because they have school-age kids and they don't want their kids at school to see an interview on the news or in a way that a child has to answer for their parent in a way that they may not be prepared for. Now, I'm not saying that no one should share stories in those ways. What we are saying is that those are things that one should consider when telling a story, so that we do so with purpose and we do more benefit than potential harm. We've had a focus on ethics in recovery storying. I've had the honor to write with internationally known recovery historian Bill White, myself, Bill White, and Danielle Torino, who at the time was president of Young People in Recovery, wrote a 5-piece series of articles on ethics of recovery storytelling. There's links to this in the back. And we wanted people to think about how we tell our stories and how they're used and some of the positive and potential negative implications of that. We wrote it to start an initiated discussion nationally on how our stories are used, and we're pleased that it was actually pretty well received across the country. So we want to think about if you're a person in recovery, or if you have lived experience from a family perspective, how to share your story in public. What is the right time? in recovery to share your story publicly. Being around a while, I have horror stories, and probably about 8 years ago, I was at a public event, and two young women, each who had a handful of weeks off of opioids, got up on stage and told the worst places in the world, their own personal hell of where addiction took them. And I'm also a clinician. I'm watching them up on the stage shake and tell their stories and recognize that they were putting themselves at risk in a number of ways. And one being that they were not emotionally prepared to share those things. They had experienced trauma that they had not properly addressed. And they didn't necessarily understand the implications of sharing their story in that way, and how it may end up on the news. So, I talked to them afterwards about talking to people close to them and hope that they were okay afterwards. But, it is possible to be too early in recovery or not in a stable place. Again, you want to think about the negative impacts for self, family, and community. Unfortunately, discrimination is a very real issue and still is around substance use disorders. And you want to think about, if you're in recovery and you're talking about being in active addiction and you live in a small community and that ends up on the front page of your newspaper, is that going to impact your ability to get a job in that community because of stigma, which of course we all want to end. And we do believe that storytelling is part of doing that, but there's also these considerations. Like those two young women I had mentioned at the beginning of the slide, is there a support system in place to help if there are consequences, if somebody misquotes you or uses your story in a way that you had not intended? Will it be around alongside other people? And how is the disclosure of the story handled? So, we want to think about the role and function of advocacy. And that's really where this new recovery advocacy movement came from, that I talk a lot about, and I have links to things in the back. We're trying to change the way that America sees persons who use drugs, people in recovery, and how we support the recovery process for people across the country. And so we could not have done that without recovery advocacy. Our entire system was built by people in recovery advocacy. Our federal funding was built by a man named Harold Hughes, truck driver, ended up in the US Senate, and our allies who helped support that. That history is really important. When we think about how do we talk about this in ways that connects with the public. And the key to this is if you see someone who is not like those others, and I'm in general terms, when somebody that you can identify with, you get a little bit more open to possibly saying, oh, that person there, I identify with that person. And so, maybe I can open up to listening to who they are and seeing them as somebody who's not a danger at risk. And unfortunately, for a very long time, people with substance use disorders have been seen as people to be afraid of, and we shouldn't be. They're members of our own families. In Pennsylvania, 1 in 3 families are impacted by substance use disorders. It's not going to change until we recognize that those people are really our people. I mentioned NRAM in this presentation today. I asked to focus on some successful advocacy processes. The new recovery advocacy movement was born 20 years ago, and actually everything that we're doing right now, this very presentation, the persons being open about their recovery, advancing a process where people can talk about recovery and change the way that the public thinks, peer services, things beyond acute care systems are all things that came from a small group of people who 20 years ago said we really need to change the way America looks at substance use disorders, and we need to change the way we serve persons with substance use disorders. And so, that grassroots movement came out of that. I've done an awful lot of work in this area across the country. There's a series of interviews with very well-known people, some not well-known people in the movement, that I'll be linking to as part of this presentation. But we want to see that. And just recognize that 20 years ago, this would never have happened. The idea of sharing your story publicly and having people recognize that that was important. And by doing that, I tell a story about going back to my high school reunion, and people ask what you do, and I told them what I do for a living. And instead of being met with people who who judged me or looked down at me. There are a lot of people who said, you know, I have that in my family, and how do I get help? And so that's really what we're looking for, that kind of dynamic. That new recovery advocacy movement, how did they do it? How did they come together? Is it for persons anywhere around our care system? We have many, many views and perspectives on how things are defined and what things are. That really is not different than the way that it was. What happened was Bill White had written a book called Slaying the Dragon, talking about recovery history back about 200 years, and the kinds of things that pull us apart. And these individuals 20 years ago were aware that there was a lot of forces that could pull us apart. And they put those differences aside and worked on common themes. And again, that I think is something that we really need to keep focused on moving forward for all of our service system to work the way it was supposed to. I want to spend a few minutes talking about different types of advocacy work that we have done. And mostly what I'm going to talk about is enacted laws. And, you know, so we were ProA was part of something called PA House Resolution 590 about 5 years ago. We were active in bringing together stakeholder groups around the state, having hearings and talking about services that could be different. Stakeholders were very active in writing the reports and prioritizing things. That report, the DDAP executive report, is also a link that we will share with you, taking a look at some of the existing laws and how they're being used. Some of the things that I would identify in their current now, and we focused on substance use workers and how they're paid lower than other areas around across our region, and how that needed to change. So we need to adequately fund care systems. We took a look at something called Act 106, which was passed when I was 26 years old, took another 20 years to get basic enforcement. And there are elements of that law that are currently not enforced. Things like family counseling and intervention services. So about 1 in 3 Pennsylvania health insurance plans have this mandated services that are not being, we're not complying with the law. And so think about that. If we have a law in place that mandates that an insurance company has to provide family counseling and intervention services, you know, you're going to hear about harm reduction next. And if a hospital can pay for intervention services to provide people harm reduction services and connection to supports, if they would have done that 20 years ago, think about how many lives they could save. And I guess thinking about doing it now is important. We also advocated for very simple things like putting those benefits on the back of cards so that if somebody was trying to access help, they would know if they were covered by those services. And there was also a lot of focus on infrastructure. Are we funding things the way that they needed to be funded to provide the proper long-term care? NIDA says that the minimum dose of effective care for the average person in the United States is 90 days. Are we providing even the minimal dose of effective care? And even though others may need more than that. ProA also had worked for a number of years to conduct a hearing in the Pennsylvania General Assembly. I'll link to a one-page set of recommendations, and the full testimony is in the back of this. When I got into this field 35 years ago, we had a much more robust adolescent care system. If we think about substance use disorders as communicable, and I will use myself as an example, I started using at a very young age. I thought at that point, incorrectly, that drugs were great, as can happen with somebody early in an addiction process. What did I do? I went to school and I shared that with all my friends. And so you think about substance uses can be communicable. It spreads, and it spreads particularly among young people as we're sharing and experimenting. If we think of us like a epidemiologist, you would want to get to you want to get to people who are experiencing a problem at the earliest stages of the process. We've lost most of our adolescent care system, particularly on the public side in Pennsylvania over those last 30 years. We are generally not treating people until after they come out of our criminal justice system. If we could get to younger people, think of all the lives that could be saved and all the resources that could be saved. So there are recommendations related to that. And we're hopeful that we could rebuild an adolescent care system that includes recovery support services to serve our young people better, and having, say, a minimum of 1 year of services from the point of going to acute structured care to recovery support follow-up. Investing in our young people makes sense. We've lost far too many lives of young people, particularly to substance use disorders. I also want to spend just a few moments talking about our vision. I've been honored to recently been included in something called the Foundation for Drug Policy Solutions, with former White House drug czar, 2 DEA administrators, and a number of other people to really look at addiction policy in the United States. And one of the first things that I put on this table, this idea, like when I got into recovery at 21, the best thing in the world that ever happened to me. When I hit 26 years old, 5 years in recovery, the stats say that my chance of staying in recovery for the rest of my life was 5 years. This is important. Think about how we serve persons with cancer. If you get a cancer diagnosis, we celebrate when you get to 5 years of remission. If you experience trouble along the way, we change the services provided, we mix and match services, increase the intensity, provide additional supports to family. We do all kinds of stuff because we take it seriously, and we don't give up on people. And if we think about that as the way that we serve persons with severe substance use disorders, we can save a lot of lives. And the other message that I would have for people out there, I've had a pretty incredible life so far. I barely graduated from high school. I teach at a university. I've had the opportunity to do so many amazing things. And really the most remarkable thing about me is that I'm unremarkable in the recovery community. So we can take persons who are really struggling with addictions and investing them, end up with some remarkable success stories. So that is something, and the 5 things there are the areas that we have focused on as an agency. We want to think about how stigma affects us. It may be the one thing that I've consistently underestimated over my time. It's kind of everywhere, and we need to be really mindful and keep voices of recovery at all levels of our care system and advocating for policies that affect us. I'm not going to have time to talk about our stigma survey that we've done. It actually works really well with the work that Shatterproof has done, and we've talked about working collaboratively on it. We have a long way to go with stigma. And just a moment on the responsibility for ending stigma, and this is the dialogue that's occurring in the recovery community. Sharing our stories was an important step. Developing ethics around storytelling is an important step, but we also are thinking about, sharing the perfect recovery story isn't what's going to change stigma in America. It's persons who have an open heart and an open mind, and so we all have a responsibility to do that, to go out in the community, share our own truths, whether you have a lived life experience or not. So that we can open up hearts for America. Because the one thing that we know is that the majority of people are impacted, and the shame and stigma, or the fear of seeking help, is one of the greatest challenges that we all face. So working through those things together is really important. And this is a slide talking about some of the legislative rights and laws that are out there. They've taken a lot of work to get enacted into law. Some of them are still not fully enforced. And again, I'll share a link at the end of my process, and we'll have time for questions and answers at the end of this process. Thank you very much.
Thanks so much, Bill, for your presentation. And then moving on to Shannon Ash, who is our second presenter of today. And again, we'll answer any questions at the end. Shannon is a licensed social worker, presently working in an outpatient substance use setting. She is the co-founder of the Everywhere Project, which is based in Philadelphia. She has more than a decade of experience in the behavioral health field and is passionate about harm reduction and supporting people who use drugs. Shannon, over to you.
Okay, so I'm going to be talking today about harm reduction and autonomy, and identifying, acknowledging, and respecting the intersection between those two topics. So first we'll be talking about the Everywhere Project and an introduction to harm reduction. We'll discuss advocacy, our approach to healthcare, policies and practice that hinder people who use drugs, as well as policies and practices that are going to support people who use drugs. So about the Everywhere Project, we were founded in March of 2020, so in the middle of COVID. And as a result of rising overdose rates across the Philadelphia area. Did that change the screen for you guys?
Yes, we're seeing the
I don't
full
know why.
screen.
Okay, sorry, let me fix that. Okay, so like I was trying to get through, so we were started in March of 2021 because of an increase in overdoses in the Philadelphia area, especially in areas other than the Kensington neighborhood. We started it with my best friend, who is an epidemiologist and works with the Department of Public Health in the Substance Use and Harm Reduction Unit. And we aim to save lives through providing access to all forms of harm reduction, including but not limited to education and safer smoking supplies, including naloxone, safe injection kits, safer smoking kits, safer sex kits, and fentanyl testing strips. We also provide training on all the above and teach people how to utilize naloxone correctly. About me, Ashley did a really good job, but I'm one of the co-founders of the project. And before I worked in substance use treatment and harm reduction, I worked in behavioral health, and I'm also an outpatient substance use therapist. So harm reduction basics and autonomy. What does harm reduction mean? What does harm reduction entail? How can I advocate more? And what's the relationship between harm reduction and autonomy? So harm reduction is a philosophy, a model, and a guide for decision making. And what that means is that we prioritize, protect, and respect people's autonomy regardless of their substance use or recovery status. Basically, our perspective is that substance use is a part of life that can be expected. For lack of better words, it's a risky behavior, just as people engage in other risky behaviors, such as speeding in the car or riding bikes without helmets. So our purpose is to try to reduce the harm to individuals by providing education and reliable support. An important thing to understand is that harm reduction is more than distributing naloxone. We do things from providing fentanyl testing strips and trainings to code blue support. The city had an issue last year because the shelters were still at COVID capacity, but the people were not. So we provided 4,000 meals in one weekend and provided a 24-hour support for a site in Center City. Collaboratively with the city, they got us buses, and so we were able to support several hundred individuals. We also provide healthy, wholesome meals, which is important, not just providing snacks and sandwiches, but actual full meals. We also will provide people with referrals to treatment, referrals to medical care. If someone wants to go to the hospital, we'll provide them transportation to do so. Or if they want to go get an assessment for treatment, we'll provide them an Uber. We'll even provide them personal transportation if they're not comfortable with that. We also provide people with drug testing services. So if they think that there's something up with their supply, we will be able to help them have that tested through the Philadelphia Department of Health. That weekend that we gave out 4,000 meals, we also gave out 1,000 blankets. It was a really great weekend. It was cold, but it was really amazing to see all the support that came and how grateful people were. Our first year in outreach, we gave out an average of 1,000 meals a day for a total of 365,000 meals. I have no idea how we did that. That's a lot of meals. But we've made a lot of great relationships with the community that has enabled us to be able to do this. We also do mobile outreach, and that's both street-based and like we physically drive around to find people when we're informed of them. And we'll provide whatever we can, from dog food to safe syringes. So for advocating in your community, I think the biggest thing that I can say is just be willing to have those tough conversations with people in your own bubble. Being willing to advocate when you hear somebody using harmful language such as junkies or crackheads. Be willing to give somebody a bottle of water if you see that they're in need. And not only valuing people that are in recovery, but valuing people that are actively using substances as well, so that they may have a better chance of reaching the goals that they're setting for themselves. Another thing is to encourage others to carry naloxone and test their drugs. That's some of the most important harm reduction tips to be safe. And we'll talk a little more about the legislation, which would be to legalize syringe service programming and expanded drug testing. So we're going to talk a little bit about how the Everywhere Project tackles education on substance use compared to some more traditional approaches. So this is from the National Institution of Health, and it's from around the 1980s. These are scare tactic approaches, and that means that they really took advantage of emphasizing the worst possible outcomes of substance use. So kind of like scared straight. We know this doesn't work, and it didn't work then. So as you can see, these images are pretty scary. It's a skull and crossbones, like you're gonna get AIDS, like don't do it, don't get high, you'll get AIDS. So that wasn't effective on it. It just scares people. Another one, this one's targeted specifically toward mothers, and talking about how most babies with AIDS are born to mothers who shot drugs or slept with men who have, and states babies with AIDS are born to die. So obviously this is very stigmatizing language. It is not conducive to providing support or help. And it would be pretty ostracizing to read about yourself, I think. This has lasting consequences because this PSA was published more than 40 years ago, and pregnant women and women and children are still significantly less likely to seek treatment for substance use disorders and are the special population least likely to receive treatment. Even now, only 1% of treatment beds in the United States provide beds for kids. So it's definitely a vulnerability within our system. Our approach to education is to be kind of as opposite as we can from that. We use warmth. We think that to decrease stigma and provide education, we need to change the way substance use education is presented and discussed, but also conversations about being unsheltered and mental health difficulties as well. So we purposefully and mindfully utilize warm colors, fun fonts, and aesthetically pleasing graphics, which help to engage and increase the reach of our efforts. So we really want to make sure that our materials can be digested by pretty much anybody. We don't want them to make people feel immediately uncomfortable or like look at it and think like danger. A lot of people use substances, and so part of decreasing the stigma is to just normalize that. So we've had our graphics viewed and shared on social media way more than we could have expected. It's led to exposure to more than 20,000 individual accounts in 1 week. Our graphics have also been translated into several languages and are being used in syringe service programs and treatment programs across the country. So the one piece that I think really helps us to be distinguished from other organizations is to provide factual information without using authoritative practices. So we had a journalist reach out to us about a month ago and did an article with her about why we do things the way that we do. And it really comes down to providing information to others the way we would want information provided to us. Things that are objective, but still not sugarcoating it or not telling the truth. So I think the emergence of xylazine, which is a tranquilizer, has been a really big example of providing that education without providing a lot of fear around it, because it is definitely a substance that it's scary what it causes to people. So there are different ways of going about it. So I had a client say to me in a group one day, she's like, oh my God, that stuff makes people's arms melt off. And I was like, not exactly. So there's a big difference between, educating people on wounds and being like, your arm's going to melt off. And we want to be able to provide factual information that has a way for people to get support for it and not just be this really bad thing's going to happen, but no solution for it. So policies and practices to support people who use drugs, flexible approaches, inclusive approaches that provide support for safer substance use and other risky behaviors to help in problem solving, decision making, and productivity. So the current legislation is the drug testing bill, which seems to have gotten messed up in the download. But that's HB 1393, and that would allow for statewide legal drug testing of people's substances so they can know what is in them. And SB 926 is a syringe services bill, which would make syringe service programs legal across Pennsylvania. In a smaller context, one practice that is very important and is in the process of being turned over is the cigarette smoking ban, the tobacco ban in Philadelphia, and which spread to the surrounding counties, has had a profound effect on treatment. People being unable to smoke cigarettes has tremendously impacted individuals, from them letting us know, like, I'm not going in, I can't smoke, I don't want to go there. And it really just takes away that autonomy that we value so strongly. So getting to that autonomy, autonomy is the right or condition of self-governing. So being able to make decisions for yourself and to make the decisions that you feel are the best for you. The principles of harm reduction are identified by the Harm Reduction Coalition, and these are just a few of the ones we think are most important, which is to establish quality of individual and community life and well-being. And that means not just looking at ending drug use, but looking at people's quality of life and how they're doing as a factor more important. Also, to affirm people who use drugs as the primary agents. So basically trusting that they will be very important in being able to reduce use, if that, is what they're trying to achieve. Also, a lack of judgment, non-coercive provision of services and resources. So that, again, goes with the autonomy, and that we're not going to force people to do things if that's not something they're willing to do. So this is just like a quick practical application, because as providers, we play a huge role in the amount of autonomy that individuals can exercise. So an example is that Mike is using methamphetamines daily and meets criteria for inpatient treatment. Mike's been participating in OP sporadically and has been unable to moderate his use successfully. You feel that Mike needs to go to inpatient, but Mike is adamant that this is not a possibility for him due to his rent and other responsibilities. So this is tough, right? Because your client's not doing better and you're working hard and they seem to be trying, but you're just not getting there. But if he goes into treatment, he would be homeless when he got out. So that's not a possible, really, that's not going to help him long term. So taking a harm reduction perspective, we seek to find alternative solutions. There have been times where I met with individuals 5 times a week for 3 weeks until they were able to get some sort of stability. And then the agreement was, if after 4 weeks you haven't been able to maintain some sort of stability, then we have to look at alternative forms of treatment. So it's kind of just really being willing to go above and beyond what is flexible. So the bottom line, harm reduction offers an alternative to addressing substance use and other high-risk behaviors. Harm reduction is more than just distributing naloxone. Education through scare tactics is not effective. Non-judgmental and stigma-free education is gaining interest and support as a result of the opioid epidemic. And you can support people who use drugs by reaching out to your local legislators and by willing to say something if you see something. Finally, harm reduction is more than a catchphrase, and embracing a harm reduction approach saves lives. Thanks for listening, and you can send any questions to Shannon at everywhereproject.org. Oh, my references.
Thank you so much to both of our speakers. We're now going to shift over to some Q&A moderated by Ashley, but please feel free to add any additional questions and submit them using the Q&A feature at the bottom of your screen, and we'll be able to get through them before we wrap today's call.
Thank you both so much for your wonderful presentations. As we launch into our Q&A, please feel free to send more questions our way, but we have a few right off the bat. And Shannon, the first one's for you, just since you finished presenting, but can you talk a little bit about the relationship between harm reduction and abstinence? I think a few people have some questions in terms of, should harm reduction be practiced with abstinence as an end goal, especially as we talk about what autonomy means to an individual and how all of that works in a person's individual journey?
Yeah, that's a great question. We do not take harm reduction as a means to the end that is abstinence. So I guess the answer to that would be no, but that doesn't mean that if that's what somebody identifies, someone comes to us and they're like, hey, I really want to go to treatment. I'm really tired of this. This is what I want. Great, let's go. Do you want me to drive you? You can get in my car. I will take you there. Like that's kind of, but we don't press people to go into treatment if they're not ready. We don't find that to be successful. Coercive treatment overall doesn't have great statistical promise. And yeah, if somebody's goals are abstinence, that's great. If their goals are moderation, that's great. If their goal is to maintain where they are, okay, we can do that too. That's not to say if I can see, like Mike in our example, if I can see that it's causing significant harm to him, I'm going to continue to work on like, hey man, how is this causing you harm? This really seems like this behavior is really not working out with your XYZ. And try to get them to be the ones that recognize that that's happening. Just kind of like a motivational interviewing approach. But yeah, no, we're not ever kind of pushing that on somebody.
Thank you. And as you continue to talk a little bit about autonomy and someone's individual journey, and this question is for the both of you, but what is the importance of including the voices of individuals who use substances in the creation of programs and policies designed to serve them? So, what is the benefit of having those voices at the table, especially as, we're designing someone's treatment pathway or program?
You can go ahead.
Here, it's vitally important to include people in how we develop policies and processes in the country, and that the example I gave of NRAM of people in recovery across the United States insisting that we provide more than fragmented care, that we elevate recovery, and not similar to what Shannon has said. We recognized years ago. I mean, I was a kid when the users were losers, and this is your brain on drugs kinds of things were put out. They were not particularly effective, and they did not share or present the positive elements of what happens to a person like me who has a brain condition of addiction when we get into recovery and are able to successfully navigate ourselves into a way of living where we're not being destroyed by addiction. So those kind of elements are important to include on the recovery aspect. We work with harm reduction groups like Elevist to look at where there's commonality between the two lanes of harm reduction and recovery, so that we're respectful and supportive of those kinds of strategies. We were the first organization in the state of Pennsylvania to sign on support the first statewide harm reduction community. 2 years ago, we signed on to the safe syringes, testified in front of the General Assembly on the fentanyl test strips. So we have actively worked to support harm reduction and sought support in from them as well, and really want to make sure that all of our voices are at the table.
I think that that's a lot more than one question, because you're looking at policies, program development, and then individuals' treatments. So the answer is definitely all of them, because But I also think that we need to have the flexibility for everyone's treatment to be different compared to or designed by what they need. The blanket approach is not it. And so the policies need to be designed to have that flexibility to allow for people to have these things. I think that one of the biggest problems that we have right now is the strict regulations on methadone. There are people that would benefit so significantly from that treatment modality, but just will not commit to being chained to the clinic, as they call it. And when COVID loosened methadone restrictions, we saw no increase in overdoses related to that. So I just think it's important for the policies and practice to reflect accurate evidence and not things that are dated and that we don't have support for at this point in time.
Absolutely. Thank you both. And just switching lanes a little bit, Bill, this question is specific to you. Sorry, excuse me. But what are some practical ways to incorporate storytelling in your everyday work? So you talked about legislative hearings and things like that, but for someone that just works in the field and is looking for a way to incorporate that into their day-to-day.
So I used some examples from in my presentation, but what you want to do is you want to try to capture real life experiences in ways that that can get people's attention. Last Monday, I had the honor to have dinner with the White House drug czar, Dr. Gupta, and I had the opportunity to. He's a medical doctor, and I shared with him what happened to me. That 30 years in recovery, I went to a dentist, told the dentist I did not want an opioid because I was 30 years in recovery. And then what happened was he said fine. I got an NSAID. They work better anyway for a dental problem, but I had a complications. I called the guy up a week later, and when I walked into his office, he was sort of rough with me. When he put his hands in my mouth, like it hurt the way that he handled my mouth. And when he got done examining me, he said, "You're fine. You're not going to get any drugs from me." And I walked out of that dentist office feeling dirty, that there was something wrong with me as a person, and so like sharing examples of things that happen and its impact on us. I mean, I got to share that story with a medical doctor who understood what I was saying because I made it a personal story. And like when we're able to do things like that, it can help change the conversation by putting a human face on it.
Yeah, I think that's excellent, and that ties in well with my next question. But what role should the recovery community play in fighting to eliminate stigma? How can we ensure that the responsibility to end stigma does not solely fall on their shoulders?
I mean, we have to actually look at discrimination. Patrick Kennedy last week was talking in New Jersey about the Parity Act and discrimination, and like we need to take a look at using my example, medical care discrimination. Was I treated differently by that physician or that medical doctor because he understood that I had a drug and alcohol problem? And we have to have accountability for that. And without that, they're just stories. That we have to enforce our laws, and we have to hold people accountable when they mistreat us, whether we're actively using substances or in recovery.
Thank you so much. And I'm going to hand it over to Michelle just for a few closing statements before we wrap up.
Thank you so much, Ashley. Thank you, Bill. Thank you, Shannon, all for your expertise, for sharing your time and resources with us. That being said, I'm also going to drop a few resources in the chat for our attendees. As I mentioned, Bill has made available a list of incredibly helpful links and resources that follow up on some of the information that was shared today, as well as some interviews that he has done throughout his work and getting people to understand how to better communicate issues related to substance use disorder, and also encourage folks to actively respond and advocate in their communities. So that link is now available in the chat and will also be attached to any post-event materials. I'd also like to quickly mention our next webinar set for November, Increasing Engagement, How to Build Community in Person and Online. The Life Unites Us campaign has recently completed the community building workbook, another effort for us to create tangible tools and resources for our partners to start thinking about how they can both engage folks in this virtual world we're currently navigating as well as in person. So the training itself will be led by our partners at the Project Good, the PGP, as well as our additional speaker from Penn State. So if folks have any other questions, please feel free to reach out. Otherwise, I thank you for your time and I hope you have a great day.